with us Dr. Don Hirschman from Columbia University, who is co-chairing this session with me, but hopefully we can loop her in for the panel discussion and overcome some of these technical issues. I'm Neil Iyengar, a medical oncologist at Memorial Sloan Kettering Cancer Center, and it's my great pleasure to introduce this panel. We're going to start with Dr. Ting Bao.
On my other computer.
We're going to start with Dr. Ting Bao from Memorial Sloan Kettering Cancer Center, who will be speaking to us.
Unless they bring us all in at the end. Maybe they just
Is there a
bring
way we
everybody
can
in
cut
at the end.
the audio from the feed so we can, there we go. We're going to start with Dr. Ting Bao from Memorial Sloan Kettering Cancer Center. She'll be speaking about acupuncture. Dr. Bao?
Thank you so much. So it's really my pleasure to be here, and I really want to thank the planning committee to invite me to be here. So today I'll talk about acupuncture for breast cancer patients, and I'm the director of Integrative Breast Oncology at Memorial Sloan Kettering Cancer Center. I'm also the immediate past president of Society for Integrative Oncology. So I'm a medical oncologist focused on seeing breast cancer patients and acupuncturist and also integrative medicine physician. So I have nothing to disclose. And first, what is acupuncture? It's a traditional Chinese medicine technique of inserting and manipulating hairs and needles into specific point in the body to reach therapeutic effect. Those points are called acupoints. So what are those acupoints? So those are usually the points on the body, on the skin, with high density of neurovascular structures with usually low electrical resistance, and generally is between or at the edge of muscle groups. So a typical acupuncture sessions involves a comfortable bed, and then the acupuncturist insert the acupuncture needles and stimulate it to the point the patient has this 得气 sensation. That's usually the sensation of feeling heaviness, numbness, or tightness. And then they leave the needle in place for 20 to 30 minutes, and then come in and take out the needles. And chronic condition usually requires several sessions. One study shows you need about 6 sessions to know whether it works or not. And then for acute condition, for example, you sleep badly in bed and have neck pain, 1 session can take care of it. So how does it work? So there has been years of research in this area. And so those are the list of potential mechanism, how it works. So number 1 is potentially work through neurohormonal pathways. The idea is you insert the needle and then stimulate the needle, and then that sends signal to the brain and activates the hypothalamus pituitary gland, and then cause change in neurohormonal peptide, such as beta endorphin, enkephalin, or those are all endogenous opiate neuropeptides. So that explains why patients has less pain after acupuncture and sometimes feel really happy during and after acupuncture. And other study shows it may work by manipulate neurotransmitters such as brain-derived neurotrophic factors. And other theory shows it may work through neural gate theory by causing those non-painful stimulation, that's heaviness, soreness sensation, and therefore block the pain perception. And also it may work through stimulate the endogenous pain inhibitory pathway, therefore produce analgesic effect. And also study has shown it helps decrease inflammation through immunomodulation, basically by decrease pro-inflammatory cytokines and increase anti-inflammatory cytokines. And then some other study also shows, those functional MRI study shows by stimulating different points, you're stimulating different brain areas, cause different activities. So those numbers, LR3 is the liver 3 point, is actually in your feet. And between the big toe and the second toe, as you can see, when you stimulate that point, different area of the brain region lights up. When you compare that with LI4, which is large intestine point on your hand, and different area lights up. So there's some point specificity there. And then it really gave us a boost when this Nature article came out in March. So basically it's a study, a basic research study on mice, and suggests there's some neuroanatomical basis for electroacupuncture. Basically it shows electroacupuncture can help drive the vagal adrenal anti-inflammatory axis, therefore help decrease inflammation. So there actually has already been lots of studies suggest acupuncture really works, has its own physiologic pathways. And then in addition, I want to mention that acupuncture has been shown to be safe, especially when it's performed by qualified practitioners. So the serious adverse events include pneumothorax, broken needles, infection, which is significantly really rare. And the minor side effects is like bleeding and bruising. Usually is like self-limiting. It resolves in a couple of days. It's a bruising. The bleeding will just resolve in a few minutes. And so going back to acupuncture for breast cancer patients, in the next 10, 15 minutes, I'll talk about 4 conditions: aromatase inhibitor-induced joint muscle pain, hot flashes, insomnia, and chemo-induced peripheral neuropathy. So the first condition is aromatase inhibitor-induced joint muscle pain. This is very common in patients taking aromatase inhibitor. And so around between 2010 and 2013, 4 pilot studies came out, and they were comparing real versus sham versus no acupuncture. As you can see, one study basically shows real is similar to sham. It's definitely better than no acupuncture. And then the other 2 also shows real is similar to sham, but Dr. Hirschman's group actually shows real is better than sham acupuncture. They're all small sample size, so additional definitive studies definitely needed. So as a result, Dr. Hirschman's group actually got the R01 from NIH. They were able to conduct a phase 3 randomized controlled trial among 226 women with early stage of breast cancer with moderate to severe aromatase inhibitor related joint pain. And then this study basically suggests that real acupuncture is better than both sham and weightless control. So this is the primary result. As you can see, those patients were getting biweekly acupuncture for 6 weeks, then followed by weekly, followed by observation. And the primary endpoint is really at the 6 weeks. So at 6 weeks, there's difference between real versus sham acupuncture and real versus weightless control, and no big difference between sham versus weightless control. The pain reduction is about 1 point on a 0 to 10 point scale. And then in addition, they showed, because 2 point pain reduction is considered clinically significant, meaningful. And then in the true acupuncture group, there's 57% of patients have this clinical significant pain reduction, whereas compared to sham and weightless control is about 30%. So that's clinically and statistically significant. And then another interesting thing is the effect is long-lasting. It doesn't just go away after we stopped acupuncture. So as I mentioned, the patients were getting twice per week for 6 weeks, followed by weekly for 6 weeks. So as you can see, the pain reduction started already at 6 weeks, continued at 12 weeks, and then persisted even after acupuncture was stopped at weeks 16, 20, and 24. And significantly better than sham versus and weightless control. So it's suggesting some kind of underlying, possibly reduced inflammatory state causing this long-lasting effect that kind of go with the basic research showing the mechanism of acupuncture. And then another study I want to mention is a trial our group at MSK recently completed and published. So this is a PEACE trial. It's the effectiveness of electroacupuncture or ear acupuncture, auricular acupuncture versus usual care for chronic musculoskeletal pain among cancer survivors. So in this trial, we were comparing basically 10 weekly acupuncture treatment, body acupuncture versus ear acupuncture versus no acupuncture. for 10 weeks. So all 3 groups were followed for 10 weeks, and then as you can see, the body acupuncture reduced pain by about 1.9 on a scale from 0 to 10, and then the ear acupuncture reduced pain by about 1.6 on a scale from 0 to 10, and the usual care didn't really change much. And then we observed them for 2 more weeks. And then the reason why this line stopped is because they were offered, to incentivize them to stay in the trial and to enroll in the trial, they were offered 10 real acupuncture treatments. So that's why we couldn't really continue this curve. But then, as you can see, both the body acupuncture, electroacupuncture, and the ear acupuncture, the pain reduction persisted, despite the fact that no more treatment until week 24. So how about other outcomes? So we also found that both intervention, ear and body acupuncture, improved pain-related functional interference, and also improved physical and mental quality of life, and reduced analgesic use. And interestingly, when you compare the electroacupuncture on the body versus ear acupuncture on the ear, the adverse event is actually different. So not too much adverse event with electroacupuncture on the body, but 10% patients have side effects when you give them ear acupuncture. That's usually the ear pain. And then as a result, the ear acupuncture group has higher discontinuation rate due to ear discomfort. So the second condition I want to talk about is this vasomotor symptoms, such as hot flashes and night sweats. So it's very common from endocrine therapy. Symptom management is very challenging. So mainly because estrogen treatment is the most effective treatment, but it does increase risk of recurrence in patients with ER-positive breast cancer. So additional treatment is needed. How about integrative medicine therapy, such as acupuncture? So there has been a number of pilot studies done, and some of them actually larger. So as you can see, some study shows both groups got better, real and sham, but no intergroup difference. And other studies shows real acupuncture is better than sham acupuncture. Eleanor Walker's group actually showed that when you compare real acupuncture with Effexor, valenfexine, real acupuncture has equal efficacy with less side effect. And then the other study also showed real acupuncture is better. So Jim Mao's group, at that time he was at UPenn, now he's at MSK. So he did a 4-arm trial, randomized patients with hot flashes to electroacupuncture, sham acupuncture, gabapentin, and placebo. So as you can see, the average hot flash score reduction, electroacupuncture is the best. And then importantly is after they stopped the intervention, the electroacupuncture group, the hot flash reduction continued, whereas the gabapentin group, the hot flash reduction bounced back, resolved. And so this is the largest acupuncture for hot flash trial. So this trial basically is a programmatic trial. It's enrolled 190 patients, and patients were randomized to individualized acupuncture plus enhanced self-care regimen versus enhanced self-care alone. As you can see, once again, so acupuncture decreased hot flash score significantly, and then the effect does not go away even at 3 months and 4 months, 6 months follow-up, and minimum side effects. And the next condition is insomnia. As we know, 68% of cancer survivors, breast cancer survivors, suffer from insomnia. And so the standard treatment for insomnia is actually cognitive behavior therapy for insomnia, CBTI. It's effective and gold standard, but it's associated with poor adherence and non-response. And also, it requires a therapist. So in some area, it's not accessible. As a result, we're wondering if acupuncture can help, just because some pilot study already shows acupuncture can help with pain, hot flash, and related sleep disturbance. And in addition, about 73% of US cancer centers already offer acupuncture. As a result, we got a PCORI grant to run this randomized control trial to compare acupuncture versus CBTI for insomnia. So mind that we use this insomnia severity index, and 8-point reduction is considered clinically meaningful. As you can see, we randomized patient to acupuncture versus CBTI, and both interventions were effective and durable, but CBTI is slightly better than acupuncture. Importantly, it's most effective for white, male, higher educated, and those patients without pain. And then last is the condition that dear to my heart. I spent past 10 years doing chemotherapy-induced peripheral neuropathy trials. And then, so basically, CIPN is a condition very common among cancer survivors. It affects up to, depends on which study you look at, 30 to 60% of cancer survivors. And right now, the only treatment recommended by ASCO is duloxetine, Cymbalta. And that was recommended based on this JAMA article, this study. They randomized patients to duloxetine versus placebo and find out that duloxetine reduced CIPN pain by about 1 point at the end of the treatment, whereas placebo reduced the pain by about 0.3. So the difference is 0.7. And then meanwhile, our group conducted a phase 2A trial, a single-arm trial. Patients with Velcade-induced peripheral neuropathy received acupuncture treatment for 10 weeks. And then the pain reduction is about 20 out of 0 to 100 scale. And once we stopped acupuncture, the pain reduction did not go away. And also, interestingly, we found out that the toxicity are different. Duloxetine was associated with fatigue, insomnia, and nausea, causing 12% of patients withdrawal. And acupuncture has mild bruising. So inspired by this trial, we conducted a phase 2B trial. It's a 3-arm pilot randomized control trial. We were comparing real acupuncture with sham acupuncture with usual care to see if it can help reduce CIPN symptoms in solid tumor survivors. And this is the primary result. Real acupuncture reduced the pain by about 2 points. Sham acupuncture reduced the pain by about 1 point at the end of 8-week acupuncture treatment. And then the real acupuncture pain reduction persisted at 12 weeks follow-up, whereas the sham acupuncture pain reduction bounced back. No big difference from usual care. So because of this promising result, we were very fortunate to be funded by NIH. It's a multi-million-dollar grant. And it's a phase 3 randomized control trial comparing acupuncture with sham acupuncture for CIPN pain, our ACT trial. And we hope to enroll 250 patients. The trial has been ongoing, and so far we enrolled 21 patients. And this is a study schema. So 250 patients randomized to real versus sham acupuncture and followed at week 8, 12, 18, and 24. Oops. And then we're hoping that we'll be able to finish this study by the end of 2024 and be able to present the result. So in summary, I do think healthcare providers should be aware that acupuncture poses minimum risk and can potentially benefit patients significantly. And it's a reasonable treatment option for breast cancer survivors to alleviate treatment-induced side effects such as pain, hot flashes, insomnia, and maybe CIPN. We'll see. And additional studies are needed. Just want to put a plug for our poster. We have a poster on this PEACE trial subgroup analysis on breast cancer patients only, comparing body acupuncture with ear acupuncture with usual care. So that will be presented by Dr. Iris Zhi at poster session 4 on Thursday afternoon. And then I want to thank all these people, especially our patients, and all this funding opportunity to help us to continue the research. Lastly, I just want to say, as the immediate past president of Society for Integrative Oncology, we basically present all this evidence-based integrative medicine approaches, and our next meeting is at the Scottsdale, Arizona in October 19th to 22. So I don't think I have time for questions, so I'll take questions at the end. Thank you very much.